Alrighty.
The Midwife Crisis podcast will touch on sensitive topics regarding the human body, sexuality, pregnancy, and all aspects of women's healthcare and may not be suitable for all listeners. I'm Kate.
And I'm PR, and this is season 2 of the Midwife Crisis, because it's not just you. Over the long break,
Thanks, COVID.
she always says that, we continue to receive some incredible emails from our listeners, and we are very thankful. We are so happy that you continue to listen, even though we weren't putting out new material. One email really touched us and is serving as the inspiration for our full episode today. As always, we're keeping the listener anonymous because we didn't get permission ahead of time, which we will continue to do when you send us emails unless you give us permission. So if you want a shout out, you can even use a fake name if you want. Spoiler alert, trigger warning. This episode will address birth trauma. And so if you have a history of this trauma, we just ask that you be mindful.
Okay, so our email reads, Hey, PR and Kate. I was wondering if you'd talk about birth trauma. I had a scheduled C-section that went wrong. I was in triage, had lost my mucus plug when I went to change into the hospital gown, and was going through the intake process of answering the nurse's questions and getting my IV. I passed out when they were putting the IV in my arm, and my son's heart rate dropped. It slowly stabilized and then dropped again. They threw a gown on my husband, put a mask on me, and wheeled me to the OR. I've always had a fear of being cut open, so I was already terrified of having a C-section. My husband came in after the initial incision was made. From the time of the final anesthesia check to the time my son was delivered was 7 minutes. He had to be resuscitated and was taken immediately to the NICU, or for those out there who don't know, the neonatal intensive care unit, where he stayed for 3 days. I got to hold him for the first time about 7.5 hours after he was born. I have a bicornate uterus, double cervix, and a vaginal septum. And that's something, it's almost like she's got a heart-shaped sort of twin uterus in there all the way through to the vagina. And that's something you can easily Google search if you want to see more about that. And so she was planning to have C-sections only. Because of this, my husband and I are terrified of having any more biological children. I'm also studying to be a CNM, and I know I'll need to find a way to work through this because I can't even stand looking at my scar. It makes me think about having to be cut open. What are your thoughts on healing from birth trauma?
Wow. That's, thank you so much to the listener for sharing what must have been a really difficult memory. That's very clear in her email. It's also impressive and exciting that you've decided to become a CNM, a midwife.
Absolutely.
We agree. It would be helpful for you to work through this so that you can be your best in your effort to support other folks that you'll be caring for. But I want to start at the end of her story. Our bodies tell a story of who we are and remind us of what we've been through. But the scars also remind us of how strong we are and our capacity to overcome and prevail. So it kind of depends on how you look at it, really. And as an aging superstar, you start to notice things about your body that you may not appreciate. And I have come to the conclusion that my body it tells a story. If you don't care to look at my story or see my story, then you need to look away. But I love it. I love it. I love all things about it. And so we're going to talk a little bit about that. A traumatic birth is defined as when an individual, a mother, father, other witness, believes the mother's or her baby's life was in danger, or that a serious threat to the mother's or her baby's physical or emotional integrity existed during the labor and birth. According to Beck, and we'll talk about Beck in a moment, Beck et al., up to 45% of women feel as though they've had a traumatic birth experience. That's nearly half.
Yep.
About 4% of women experience post-traumatic stress disorder, PTSD. It doesn't just happen during war and other big, huge world tragedies. It happens to everyday folks, and in this case, to someone giving birth.
Absolutely. So, I think it's important to note, and I have said this before, birth is traumatic, period. It's traumatic to you. Your body is literally opening up and expelling
Yes.
a person. It's traumatic for babies. They're getting squeezed and pushed and in funky positions. And so sort of by definition, I think it is. And to say otherwise is doing a disservice to people who are birthing because it is. You have to know this is momentous, right? But it shouldn't be necessarily, upsetting, emotionally traumatic. And, that kind of thing, I think, is what stays with people. Personally, with my first birth, I felt that it was a bit traumatic myself. I had a really quick birth. We've talked about it before. And I still remember sort of the moment of birth when, I could hear that they were listening to the baby's fetal heart rate, and it was like in the 60s. And, any of us birth workers know that like thump, thump,
Oof.
thump. And you know that that's not a good sound. And so they were like, come on, we really need to give a good push. And I gave a good push. And while I was pushing, they said, stop pushing. And they all started screaming at me to stop pushing because I was pushing too well. And I had a really bad tear. And I'll never forget the look on my midwife's face when I looked down the bed, and she looked horrified.
Whoa.
She just looked like she was like white as a ghost, holding pressure on my bottom. I was totally unmedicated, but all the excitement had kind of numbed me. And she was just like, go get the doctor, go get the doctor. She kept saying his name. And I was like, oh my God, it's really bad, and I just remember feeling totally freaked. And that followed me a bit. So when I had my second child, I remember we've talked about this briefly, and you guys can hear about our birth stories in our first episode, but I recall with my second kind of going like, oh man, I don't know if I could do this again, because I was kind of remembering those memories. And actually right at the time of birth, I refused to push him out because I was so traumatized by being told not to push and sort of doing the quote unquote wrong thing and harming myself that I just wouldn't push him out. And that poor baby had all kinds of petechiae all around his head from just being squeezed by my vagina because I refused to push him out. But yeah, I mean, even for me, I've pulled away from those. Obviously, I've been able to attend to people's births and families, but I remember it, and actually, I get sort of like a compression in my chest when I think about it because it can be really scary.
Yeah, for sure. We've also talked about my first birth story and how it did involve trauma, and you can listen to an earlier episode about that. But the first baby, he had forceps. Mind you, I had no epidural anesthesia, that kind of thing. It was a forceps birth, shoulder dystocia, which means his shoulder got stuck. His clavicle was fractured, because that's how he got out. A fourth degree laceration, which means that I tore through my butt so that he could get out, not on purpose, not on anybody's purpose, but it just happened. I had a hemorrhage after he was born. And because when you have a baby that weighs 11 pounds, 4 ounces, you have a hemorrhage and measures 23 inches. His APGARs were 3, 7, and 9, which that's not so hot. He spent the first 30 hours in the NICU, and I couldn't even see him because I couldn't walk because I had a hole in my culo that wasn't supposed to be there. I sort of blocked the trauma, I have to say, until I was in labor the second time. And that happens too, you just don't think about it.
Right.
And some folks say that you get amnesia, and I didn't really feel like it was amnesia. I just thought that's not important. What's important is that I have a baby, and I can't wait to do this again. And when I went into labor the second time, I remember thinking and saying out loud that birthing babies is not a good idea.
Yeah.
And didn't we say we were going to adopt? And my then husband said, no, what are you talking about? You're delirious. And fortunately, the second baby was easy peasy. Said no one ever who had a human come out of their hind parts. But it was much easier than the first time, and there was no trauma. And it was just really like your imagined beautiful type birth. And that's something also to kind of think about, that if you have been traumatized, that the second go can be a nice go.
Healing.
definitely.
Yeah. Now, a lot of the recent research on birth trauma comes from Cheryl Tatano Beck, who's a DNSC, CNM, FAAN. So basically, she's got a bunch of titles, a bunch of stuff under her belt. She's actually a faculty member at UConn right now in their nursing school. And she's just well-published, awesome, distinguished researcher. And in her research, we were able to pull a lot of information today. So we did reference her in our episode notes. One important thing that she notes is that all birth trauma looks different to each person. And no matter what it looks like, it is valid birth trauma if you perceive that it's there. So just because you as the, birth attendant or the nurse or the support person were like, oh, that was great, you did a great job. That person might be shook inside. Something might have upset them, and that means that it exists.
For sure.
And I think it's really important to note that we may only think of birth trauma in things like stillbirths or anesthetic failure, where people aren't numb, starting surgeries, things like that. But it can be as simple as just having an unplanned C-section when you were planning, a quote unquote natural birth. And again, if you want to hear what we think about natural birth, we have a whole episode on that too. Or, if you have a baby with an initially low APGAR score, those things, of course, can just trigger something and make people concerned.
Or a cesarean that didn't go as expected or planned, like our listener experience. She knew she was having a cesarean, but she wasn't expecting it to be in that sort of crazed and chaotic manner that it happened.
Right.
I just speaking of trauma, an example of something an issue that the birth, in my perception, that the birth was very beautiful, is a patient had been told she was having a girl. And so she called me when her water broke. And I said to her, well, you're not contracting. The water's clear. The baby's moving. Why don't you just hang out at home for a while and call me back when things kind of pick up, when they start to, sort of escalate. And she said, sure. She had no problem with that. She was comfortable. And she started washing clothes, the baby's clothes. She hadn't washed the baby's clothes, which, I'm so impressed that she washed baby's clothes, because I'm going to fess up. I didn't wash shit.
Yeah, I'm pretty sure I just ripped tags off with my teeth as I was,
changing it over
changing exploded pea soup diapers
over the baby's head. Listen, they lived. They're fine. I'm not going to worry about it. But she was washing all the baby's clothes. She gave birth. She had a really nice labor, as we would perceive. It was normal. There were no trauma. There was nothing concerning. And the baby came out, and I said, oh, it's a boy. And she lost it because she was expecting a girl. And she was, it was really, that was a trauma for her, because she had been told that it was a girl. And she was expecting that. She washed all the clothes that night before. So now she had no boy clothes, and the whole room was set up for a girl. And that was traumatic for her. She told me that she had problems bonding. She didn't really want to hold the baby after he was born. He was He was perfect. He was so adorable and perfect. Thankfully, his dad was there, and he kind of said, I'll hold him. I'll do it. She was depressed postpartum. She said she had trouble nursing him because she didn't really connect with him, because that wasn't who she was expecting. And ultimately, when he was about, I don't know, maybe 3 months old, she got pregnant again and had a girl. And that wasn't in her power, but it just happened to be a girl. And she felt like, because she continued to be a GYN patient of mine, she felt like that fixed it. So people's trauma comes in different forms. It's really interesting. According to Beck, birth trauma can have a ripple effect, which brings me to Beck's research. For mothers, including, it can have an impact on breastfeeding, on subsequent childbirth, and the anniversary of birth trauma. That particular patient also, even though she was told she was having a girl, just kept wanting every visit. Can I see again? Can I see again? And no, we don't do ultrasounds unnecessarily.
Yeah. But it's hard for me because I feel some type of way about that, because I feel like gendering a person before they can tell us what their gender is feels so wrong to me.
I agree.
And we never did it,
yeah.
like until like the 90s,
Yeah.
pretty much. Like you didn't know. Like my mom didn't know with any of us. I mean, I don't know about
No,
you, but
I knew nothing until people showed up.
You're like, it's a baby. Like,
Right.
I don't, and I feel like we should be doing surveillance, but I don't know. That's so hard because people do really seriously mourn.
Yes.
It's like they lost someone
Right.
if they were expecting it to be different or if they, got a surprise. Because guess what? Even our best testing, our self-repeatable DNA is not perfect.
No, nothing
And,
is 100%.
and who knows? And then you're going to mourn that anyway if your kid is 4 and is like, hey, guess what? I'm a girl. And even though I have a penis, I'm a girl,
Right.
And so I don't know. Sorry, this is off topic, but
no,
it's like
it
just
actually
listening to that
isn't
is hard for me.
It's part of what we do, the intersection of discussion of intersection that we do. And I think that you're right. And I think that it's really important. And I did not know and I applaud my patients who say, I don't know. And I say, well, you're having a surprise because I did not know. And that doesn't mean you have to do what I do, but I just feel like it's all a setup.
Yeah.
It's set up for a letdown sometimes.
You're just going to have your baby. And,
Right.
and if everything's great, like that's great. You guys are going to learn from each other. You're going to learn to know them, whoever they are.
So this ripple effect can impact breastfeeding and subsequent birth and the anniversary on the birth trauma that's happening every birthday. You're kind of thinking about what you went through. There can be difficulties with infant bonding and an increased risk of postpartum anxiety and depression, just like my patient had. And while the impact on the mother or birth person is the main focus here, fathers and clinicians who are present at traumatic births can also experience a secondary traumatic stress. The midwife who caught my first son never let me forget how that birth traumatized her and how that was the worst dystocia she'd ever had. And she would tell people we were friends socially, she would tell people at dinner parties. And I was like, could you just stop talking about that? But she was traumatized.
Yeah. Yeah. The anniversary of the birth trauma, hearing that, I remember thinking as I first was reading through the research, like, oh, that's the baby's birthday. And it's supposed to be this day to celebrate the baby and celebrate the year of what happened. But I can't imagine how upsetting that is. That would be like the anniversary of the time you were assaulted. You know what I mean? It's
Exactly.
if something awful happened to you on Christmas and every Christmas or whatever, you have to relive it. I mean, and that must be so difficult to balance, being loving and supporting of your child and also working through what you went through. And so I think that's why it's important that we do work through these things. Additionally, no one is asking the mother on a child's birthday how they're doing or how they are. And even after the baby comes, a lot of times, you go to see the baby, not the mom. And we've talked about this. We did a microsode where we talked about the importance of, focusing on the birther when someone's had a child. But something I learned from PR, which I love, and I've been carrying along with me for probably the last 5 years or so, and even my children, experience this, is that we should be celebrating the mother or, the birther on the day of their child's birth. Happy birthing day is something that I've always heard PR say and that her babies say to her. And we've sort of adopted that too. I say that to my own mother. I like to get my mother something on my birthday.
I always give my mother a gift on my birthday.
And even this year, my oldest turned 8. And when I came in from work, I had worked a call shift the night before. I walked up the stairs and he said, "Happy birthing day, Mama." And I just thought oh, it's so beautiful. So remember that we need to be checking in with people, see how they're doing. They're a huge part of this, right? Give them a chance to share because they're the star, really. This is what happened. If they want to relive their birth, whatever, glory, stress, let them.
Absolutely. In subsequent births, patients may find another pregnancy to be full of anxiety, panic, and wondering if the next birth is it going to be more trauma or will it be healing? As in my case, it was more healing because it was so delightful. In other cases, it can just be really traumatic, as in your situation, where you were just really afraid. And it's important that, patients, clients feel like they can discuss what happened, what's going to be, what are the expectations? what's leading up to the birth, what's going to be happening. What do you hope to accomplish this time, especially if you've had birth trauma?
Right.
And I often tell patients, you're not asking for the unreasonable because you want to have something the way you expect and you have in your mind. But let's just talk about why you are in that place and why, you sort of are fearful of the adventure.
Right.
Because that's kind of what it is. It's an adventure. You don't know what's going to come forth. And I also tell them, listen, you're not a seahorse. Of course, you're not a male unless you're trans. But seahorses, I've talked about this before, they like spit like 1,000 babies out at once, little seahorses in the water. And I tell them, you don't get that many chances. And so each experience is really important. Even if you have 10 babies, it's still, each one is important to you and how it turns out. And it should be how you want it to be to the best of our ability and yours to sort of come through that.
And I think I just have to say for birth workers out there, nurses, midwives, doctors, whoever, you need to really resist the urge to label this person as annoying, a troublemaker, like a pain. Oh, look at what they gave us this letter. Let's show it to every single person on the floor and laugh about it, because that is messed up.
Birth plans.
Right. And I mean, really, just because someone is asking you to do something that really is within your scope of your job, but it may make things a little bit trickier, it's not appropriate to, be teasing them or talking about them. You need to be supporting them. We need to be setting realistic expectations for patients, but also doing our best. And sometimes that might mean, within the best of your ability, giving a little extra. Like I recall I had a patient who had a traumatic birth, crash C-section. The baby did not survive. And she got pregnant again within the next year with twins. And so she was having another C-section, a planned C-section. Twins already can be problematic. Right. So we, sort of worked through her entire, pregnancy, talking about what was going to happen. And she asked me to be there when she had her C-section. And I did. I had to stay extra after I'd worked a night shift. But for me and for also the doctor who did the C-section, who was the one who did the C-section where her baby did not survive, it was kind of healing for all of us. We got to go through it together. We got to work through it. I got to be there with her and we cried and I helped her hold her babies. And I mean, it's just, and for me, I needed to do that for myself. I think same thing with her surgeon. I think for all of us, we needed to kind of go through it again and see that things could be okay. And it was extra work. It was something that I didn't get, paid for. And, I was having to stay after I worked a 24-hour call, but it was important to her. It was important to me. And I think sometimes if you have the ability to do a little extra, a little something, do it,
It's an investment that you get a big return on, especially in the healing process, that you got to be with her when she was successful with her twins and the surgeon and so forth. I still remember my first shoulder dystocia, I still remember I see the patient's face and all the people running in the room. And
so a shoulder dystocia is?
A shoulder dystocia, that's a good question, is just like I described for my own son, when the baby's head comes out, but the shoulders are either really too wide or in a odd position that they're not following the head. And so they're stuck.
We've talked about with birth how babies do a lot of work on their own. They do something called the cardinal movements. And so there's a bunch of rotations and things they need to do. And sometimes if they're unable to do those, it's difficult to deliver the baby.
And so I still remember that happening and the patient and all that went through. And, I remember some slow starts, which slow starts are when the baby comes out. And it kind of sort of is deciding, do I want to be on this planet or do I want to just go back to where I came from? And so you're not getting them to cry and sort of breathe and color up and stuff like that. Resuscitations, they all bring back that twitchy, they make me twitch. If I think a baby's going to get stuck, that provokes lots of anxiety in me. I make preparations for it and we do simulations all the time at the hospital. And so we're trained to cope with it. But it still makes me sort of, do you have all the equipment in the room? Do you have, I'm just going through the steps in my head. because it just makes me twitchy.
Yeah. I still remember my first sort of difficult birth as a nurse, where I was the nurse for the patient. We had a wonderful night together, like really bonded. She was pushing. Baby's heart rate seemed fine throughout. And then right sort of towards the end, which sometimes happens, the baby just wasn't coping as well. But she was very close to delivery. So the clinician was there and the baby came out, but the baby came out just with sort of none of that drive, no cry, not great perfusion. So a little blue, a little purpley, which again can happen.
Right.
But within the first minute, this baby was not coming around. And that's sort of the time that we give the baby to transition. And I still remember because the doctor was freaking out and I was the nurse. And so the doctor was screaming like for help. And I remember having to start all the resuscitative process for the baby. And it was
because we're trained to do that also.
Right.
That's not a joke. That's a serious thing.
Right. I'm laughing just because it's uncomfortable to think about how stressful it was. And and it was truly traumatizing to me. I mean, after it was all said and done, I went in the hallway and I just sobbed. Like I just totally cried. And I was leaving for a vacation to Ireland the next day. And I remember I was so worried about the baby. And before I had even left, my sister is a NICU nurse. And I was like, can you just tell me, is that baby okay? And she's like, the baby's fine. And the parents, and I actually have a little bit of guilt about this, but the parents came and found me about a month later when the baby was getting discharged home. And the mom came and found me and said, I just need you to know, like, this baby's okay. This baby's coming home with me. And you helped do that. You kept this baby alive for the first, minute until there was help there. And you did good. And I didn't, she didn't need to do that. This was her trauma. But clearly she saw that I went through some kind of secondary trauma. And I will never forget that because it meant so much to me. And then years later, when I was going to midwifery school, another nurse who I guess was friends with her outside said, one of my friends was talking about her birth story and she was talking about her incredible nurse and it was you. And it was this patient. So I think
it was our Kate.
I think it just says something about how important, you don't realize how impactful your small actions can be. And so being able to talk with people, being able to go through these things can make a huge difference. And we're going to talk about that in a little bit when we talk about the prevention. But should we take a quick break?
Yeah, why don't we do that?
Hey guys, it's Chelsea.
And it's Ashlyn, and we are the hosts of
Will There Be Tequila? Ooh, we did it on point! So it's a show where we talk about things that are going on in our lives and the world around us, because the world's on fire and all that fun stuff. And we also have a little shot on the side.
So yeah, be sure to check us out every Tuesday wherever you listen to your pods. So Apple Music, Spotify, SoundCloud.
Literally anywhere.
Drink responsibly.
Okay, and we are back with the Midwife Crisis. Today we are talking about trauma in childbirth. And so again, if you had taken a little break and you've forgotten, we just want to give a little bit of a trigger warning for anyone who may be suffering with their own traumatic childbirth, that we're going to talk about some things that might make you feel a little bit uncomfortable in some kind of way. And so that's our little warning. So when we're talking about traumatic births, we're talking about sort of how this is what happens after the situation is perceived by the person, but we haven't really talked a lot about preventing them. And I think there are some things that we can do to try to set people up to have a good experience. And so some risk factors that we can look at in patients prior to pregnancy, such as mental health disorders or prior trauma, especially sexual assaults.
Yes.
Some poor quality of provider interactions. So if the patient, comes in with you and says, listen, I saw your partner and I was really upset because of X, Y, and Z. Those are all things that you can address before the birth. You can talk with the patient. You can discuss what upset them or what things they're anticipating, or, if they have a prior trauma, what that was like and what you can do, what they think you can do to try to make it better. And as a patient, if you are not jiving with your care provider or you have something that bothers you about an interaction or something you've overheard or something that went on, you must speak up. And if you're not taken seriously, you must find a new provider. I don't care if you're 37 weeks. Like, you need to find some place where you feel safe.
Because you are not a seahorse.
Exactly.
And so this is important. And in doing part of that prevention can also be education. So childbirth preparation is important and in it, including having it cover the good, the bad, and the ugly. So you can just sort of have a notion of what could possibly happen. Not all bad, but you're expecting good, but just to be prepared and to understand. I think that that's really important.
And I think it's important to note that there are some really wonderful childbirth education programs that focus on like the normal. And and again, we talked about this when we talked with our natural childbirth episode, but they'll say things like your body's meant to do this and like it's going to be, everything's going to work out because it has to and that kind of thing. And I think that can sometimes be damaging because then when things don't work out that way or your
It's a
body
setup.
didn't do right.
You feel that you're a failure.
Exactly that. And so I tend to, I taught childbirth education. I think PR did
So
as
did
well.
I.
And when I taught, I made sure that I told people, yes, 99% of the time, it's normal. Your body's going to know what to do. It's going to be great, blah, blah, blah. But also, there is a possibility that not everything will be perfect. And here are some of those things you might expect. And I would go over internal monitoring or, what happens if the fluid's not clear, or C-sections and what the difference between an emergency section and a planned C-section and different types of anesthesia and all different kinds of things, because even though it's scary, you need to know, because I think knowledge is power.
For sure. And you can't, if you don't have that knowledge, it's really difficult to participate in shared decision making. And
Right.
that is, we're not doing things to you. We're working with you to try to get a healthy mom and baby and to get a hopefully a positive outcome. And so, your provider should be explaining risks, benefits, alternatives to whatever it is that's being presented. Some of that you can learn in childbirth education so that when it is presented to you, you understand what folks are talking about. Interventions identified by Beck as helpful for prevention of developing significant birth trauma stress include postnatal debriefing. So that's after you have the baby, having someone, this is the most important, having one of the key players or your birthers come and talk to you to process the experience, the good, the bad, and the ugly. And so who attended your birth, have them come and sort of explain, this is what happened. I review the details of the birth after mom is settled. And it's a brief process, but even on a perfectly straight ahead, textbook normal type birth, I still go over what was happening, when she was pushing, because it's almost like an out-of-body experience. So you're there, but you're kind of, was I really? And so I talk about when the head came out, when the baby came out, and so on and so forth. Because they're going to retell that story, and it's like, let's all be on the same page. Not that it's, and I don't know what was traumatic for her. Maybe she thought her husband screaming, the head is purple. Well, it's supposed to be until the baby comes out and starts breathing.
Right.
And so covering that kind of stuff, because that could be traumatizing to her, and then you can clear some of that up for her. So I think it's really, it's important to do that. Perception is her reality, but sometimes reality, it can be two sides of the same event. And so that's why I think it's important to kind of discuss it. And if she says, oh, no, that's not what happened, then you can kind of go over what happened and why, what was appropriate, what wasn't.
Yeah,
whatever.
and we're not saying you're trying to change her,
No,
anything.
absolutely not.
We're saying like clarification.
Absolutely not.
Yeah.
It's just a good idea to circle back and even if the patient and the family seem fine, and ask if they have questions, if they have, if they want to review the events and that kind of thing. Like, for example, shoulder dystocia, the mother may say, they jumped on my belly, like 100 people came in the room and one of them stood on a stool and jumped on my belly, when what they were actually doing is giving suprapubic, like on your pubic bone, putting pressure to try and flatten it so that the baby's shoulder can kind of clear itself and come out. And so that's something that's easily cleared. No one was, not to make her feel like she doesn't understand anything, but just sort of say, this is what we were trying to do because it was important to help your baby exit.
Right. And I think in those situations, if you've ever been in shoulder dystocia, you know probably that they can be a little traumatizing, I'm sure, because they're loud and people come in and all of a sudden there's all these people here and they're, talking over each other. And we try not to make it be chaotic, but sometimes it is. And I think, as a birth worker, if you heard someone say they pushed on my belly, what are you thinking? Because in my head, I'm thinking, oh, that almost sounds like they did what's called fundal pressure, which we don't do because it can cause a shoulder dystocia.
Exactly.
And so clarifying with the patient within that, initial time frame that you are actually doing suprapubic pressure to release a shoulder is a big difference. And so I think it's important that, again, we empower people with the knowledge. And I always tell people as well, you should know everything that's gone on to your body. And if you don't know, like when people come in for the GYN exam and they're like, I think I had a pap neck last year. I'm like, no, ma'am. You need to know because this is your body and your health and you are your own advocate. So like we need to be making sure that people really understand.
I do tell them, I want you to know what I know. And typically when I know it.
Mm-hmm.
And so that's why there's a time when we're not talking about that. And that's why I circle back and say, let me bring you back to where we all are. And as Kate said, we're not trying to change your notion of the whole thing, just to sort of I should know more about you than you know.
Right.
About your body. I don't care if I'm looking inside and you can't see inside. You have a right to know all the details of what I see and what I'm doing.
And that being said, I think it just needs to be at least offered and explained if they are tolerant of it. Because I also have people who are like, just do it. I don't want to know. I don't want to hear. Sometimes I'll hand people the mirror and say, I just want you to see and they're like, no. and that's fine too, of course, because, it's up to the patient. But, if they want to be empowered, let's allow them. Something that can be really helpful as well is expressive writing. Journaling, and just working through your feelings. So getting everything down on paper, going through it, trying to see what you remember, what you don't, maybe talking with people who are there, filling in the blanks, sort of making the narrative for you so that then you can work through it and see and pull out which pieces were the pieces that were most upsetting.
Right.
For me, as I said with mine, it was everyone going, don't push, don't push, don't push. And I just remember that because I just kept thinking, oh my gosh, I did this to myself. They told me not to push and I was a naughty patient and I couldn't, but anyone who's had a baby knows you can't stop that. And so having to work through that and work through that language was really big for me. Another thing, and we'll talk about it till the cows come home, is cognitive behavioral therapy, AKA therapy. And this can be brief. Not everyone needs therapy that they do for years and years and years. Some people who
like
have...
us.
Right, exactly. Not like us girls. Some people have just distinct sort of traumas that they need to work through. And so maybe brief cognitive intervention, 6, 12 weeks.
Amen.
And guess what? We have it now online. Yes, queen. Yeah. We have Talkspace. We have BetterHelp. Almost every therapist that you can go to their office offers telehealth as well. Exactly. And so as long as our insurance companies keep paying for it, please, universe, let that happen because it's so helpful for people.
Yeah.
When someone has a newborn baby and they had a 4th degree tear and they can't get off their butt and sit in the car to drive there, to allow them to be able to talk to you on the computer, on your phone is such a gift. And you shouldn't be scared to use it because talking through it, you may not even realize what you need to say or what you need to hear.
Sometimes talking through it is a form of self-healing. It's you're going to a therapist, you're thinking that person's going to help you, but in essence you are really doing the work and you're helping yourself. I think it's helpful to consider a postpartum doula, to consider a doula intrapartum, like while you are giving, to assist you when you're giving birth, to help advocate for you, especially if you have a partner who knows you and is into you, but may not be well versed in sort of opening up and advocating for what you guys have kind of thought about and would like. Doulas are super helpful. So we're going to talk about, we're not going to talk about this in depth, but there are 9 instinctive stages of the infant during the first hour after birth. And so we put baby skin to skin with mom in the first hour for many reasons. There are many reasons in these 9 stages for doing that, because it sort of facilitates bonding, it facilitates breastfeeding, it facilitates a lot of things. Imagine Felipe was taken, that was my first son, he was taken away from me like right away, and I didn't see him for 30 hours because I couldn't walk. And Max was taken away from you, and they both were taken to the newborn special care, and so to the NICU. And so the experience the second time when I had a baby placed on my chest was like magical.
Yeah.
It was magical. And I didn't not bond with Felipe, but it was like, oh, this is like in the video.
Yeah. I will say for clarification purposes, Max did stay with me initially, but then they took him away because he was cold, which is a practice that we don't really do now. Now we will bring the warmer into the room if we feel that the baby needs a little additional, exogenous warmth. But in my case, he was taken away. And I remember after like an hour or so being like, where is my baby? Like I started to think I was going crazy. Like, did I even have a baby? Am I making this up?
Oh, come on.
Right?
That's what I thought too.
It's bananas.
Yeah, it is bananas. So these stages are, the birth cry, the first stage, when everybody wants to hear the baby cry, that like generates applause.
Yep.
And the baby starts to breathe. And then there's sort of the relaxation stage, and the newborn doesn't really do much. The hands are relaxed, and it's just sort of getting used to the planet, basically. And the birth cry is kind of stopped, and the baby's skin to skin and covered with a blanket, and you're taking pictures and all that. That's not part of the phase, but that's what your stage, that's what the parents are doing. And then there's kind of an awakening, and all of this is happening really rapidly. The newborn kind of exhibits small thrusts of movement in the head and shoulders, and kind of preparing themselves in the few minutes after birth for what's going to happen next, where they kind of start moving their mouth and maybe even showing some interest in nursing and starting to root and rooting. Do you want to talk about rooting real quick?
Sure. So rooting, if you've ever touched like a cheek of a baby and they turn their head towards it. So rooting is this natural instinct that they're born with where they find the breast, they find the nipple.
It's like magic.
It's like magic. Yeah.
So the baby may rest at any point, and you can have periods of rest and activity throughout that first hour. And the next stage is called crawling, but the baby doesn't start crawling. But studies have been done that if you put a baby on the chest of the birther, they will work their way to the nipple, to the breast. They will, especially if there's any milk that's expressed, they will work their way up there without you even lifting them per se. And so it's just fascinating how humans have evolved. This stage begins about a half hour after giving birth. And then there's familiarization. They lick the nipple. And I always tell patients, even if they aren't latching, just let them sort of get used to it and lick and play with it, just so they can kind of get a notion of what's going on. And it gets your body ready for what's about to happen.
Yep. And a lot of times what you'll see infants do as well is they'll sort of stick their own fist into their mouth and face and kind of suckle on it. But that's because the amniotic fluid actually gives off a similar scent as the chest and breast and nipple. Right. And so it helps the baby. It's like a hound dog, it's like they get a little scent, and now they can kind of follow it to where they're going to get some food.
Oh my goodness. Even just thinking about this makes me I just get like a little endorphin rush.
I get like phantom letdown. You ever get that like little zing down like your boobs? I'm like, whoa.
And it can take more time if mom has had analgesia, anesthesia during labor. More time. You may need more time with the skin to skin and to get the baby to start suckling and stuff like that. And that's not wrong. It's not wrong or right. It just is. It's okay.
Right.
It's just your experience. And the final stage is sleep, and the baby and sometimes mother too fall into a restful sleep. And they sort of sleep for about 1.5, 2 hours after birth. So in that first hour, you don't try to. These stages occur pretty naturally, and you try to get baby sort of onto the breast or the chest just for a sample.
And even if the person is not intending to breastfeed, they can absolutely still do skin to skin and kind of go through all these stages, because there's still evidence to show that it helps the baby stabilize their vital signs. And, it helps them regulate their body temperature and keep their blood sugar up, so that even if their intention is not to nurse the baby directly from the breast or chest, which we're never going to force that on anyone.
Right.
They should still offer that. And even let's say it was a surrogate pregnancy, the parents can do skin to skin, or the support person can do skin to skin with a baby. You're still going to get some of that good benefit from it. And I think the biggest point of this is, even in a traumatic birth experience, just like how PR said, even though the patient didn't want to hold her baby, she had the partner do it and then eventually tried to get the mom to do it, because it's helpful for everyone in this bonding stage. And even in a C-section, we really need to try to encourage, the staff as much as we can to try to get the baby skin to skin, even if it's just the support person holding the baby cheek to cheek with the mom. There's something there, or the birther, to have that interaction with its parents, so that we can start this bonding process.
And that can occur with the birth support person. It like if you can't do it in the C-section, but the person who's there supporting you, be it your partner, they can do it skin to skin. And
Absolutely.
so the baby still gets skin to skin. It's not a right or a wrong, and no one cares if it's a hairy chest. The baby doesn't know. The baby doesn't even know what hair is. So
and we already talked about hair in our last episode. We don't care. We're not going to judge.
No, absolutely not.
So one possible positive outcome that can come from traumatic births is something called post-traumatic growth. I mean, and this is not just in births. It's anyone who has a post-traumatic episode or instance. So basically what this means is that individuals are able to surpass and kind of work through in some part of their lives what was present before their struggle with the trauma. And so they're kind of not getting rid of the trauma altogether. It's not that it goes away, but they're able to learn how to sort of live with it. So as many people will say, they're not getting over it, they're working through it. Yeah. And this growth consists of 5 dimensions, and people may not have all of them, but they may have some, which an appreciation of life, learning to relate to others, personal strengths, new possibilities, and spiritual change. And so these are all things, if you can think of anyone who's had any kind of trauma in their lives, many times if they're able to have some kind of positive outcome, it will be some or one of these, pieces where people, again, are learning to appreciate things or look at things in a new way, or, figure out new meaning for what their life is like and for.
We wouldn't be us if we didn't cover a little of our intersectional work. And so I'm just going to quickly talk about the Black Latinx community. We're not monolithic, so what I'm speaking are examples, and there are many, many more that that we will not cover and can't always cover. But I think it's important just to raise it up. Trauma happens to us, good, that results in good things and not good things. And if we're not medically inclined, we tend to believe that's how things are supposed to be. And so I feel like as people of color, we don't always feel empowered to question the process. And that's why I said doulas can be helpful, because they know when to question the process and when to support the process. And it's also helpful if you have a doula who looks like you when you're in the population of color. And so, or just even birth providers that look like you in some aspect or another. And so that's really helpful. Language barriers, that seems like it's pretty obvious, but
that's a huge one.
It is super huge. And even with interpreter services and all of that, it's not quite the same as when you have someone who's speaking your same language. And I witness that all the time because, I'm bilingual, so I can speak with the Spanish patients just as well as the English. But also when I witness our providers at the hospital who are Arabic speaking, and just the mom is so thrilled to be able to have someone understand. Sometimes the interpreter services will be a male. If they're Arabic speaking, often they're Muslim. And so that doesn't sort of jive with having a male involved in their process and all of that stuff. So language barriers they matter. The midwife who attended my first birth never came back to review the birth experience with me and its inherent trauma. And I'm not sure I don't think that had to do with my color. She just didn't. I think it had to do with her. But I think it had to do with her thinking it didn't matter. It was okay. And that she could just walk away. And when she saw me 6 weeks later, it would be all right. And I think often people of color aren't listened to anyway by the medical community. There are all kinds of biases and thoughts and suspicions, and they're strong and they don't need pain meds, or they're drug seeking and they don't need it, but they want it, or there are all kinds of things. There are all kinds of ill assumptions about my community.
And we've talked about those disparities.
And we have. And another layer on that distasteful cake is if you are a person of color and also in the LGBTQIA community. And so that is just even worse.
Yeah. I mean, well, and that sort of pops into, of course, what I'm going to just mention briefly is, again, I also am not speaking for everyone, but when I'm looking at some of the information, same kind of things, different sort of outlook, right? So in the LGBTQIA plus community, there can often be a fear of being misgendered. You know, if you're a non-binary or you're a trans male having a baby, being a birther, then it is so easy for someone to, name you, say she or her or mom and dad and all these like heteronormative wordage and verbiage that we tend to use. I had a patient who I labored with all day. The patient and her wife ended up in a C-section. We're back in the C-section. The patient's all ready. And someone goes, "Can you go get dad?" It was the nurse. And I was like, "You've been with this patient for 10 hours. And you're going to say right now, can you go get dad?" And guess what? This patient on the table, she is awake. She fully heard that you just said that. Like, what is happening?
Whoa.
It doesn't take a lot to pay attention. And she didn't correct herself, which, I really think she was not being malicious. But when we do make those mistakes, we need to correct them. We need to bother to correct them and not be asking for forgiveness, but just moving on from it.
We must always consider that your intent, the impact of what she didn't intend anything. She just was going through the motions. But the impact of what she did and said, it's lasting. That's something that those people will remember hearing about their birth experience. And so,
yeah. As well as, some patients, especially in the trans and non-binary community, again, may have a difficult relationship with their birth sex organs. So things like vagina, vulva, uterus, breast, we need to do our best to, again, communicate with these patients, say, what are you comfortable with? Are you comfortable with me saying this? Are you, how would you like me to refer to it? And that's why we try to change the verbiage. And PR and I have tried a little bit when we're talking about things like the birth crawl and everything to chest feeding, breastfeeding, providing the baby with milk, mother's milk, whatever. We shouldn't say mother's milk, I guess. But, we're trying to be inclusive in our language. And I think that that'll go a long way, especially if you just say to the person, "Hey, I want to be inclusive with you.
Right.
How would you like me to do this?" And again, that talks to a little bit about letting yourself be a little uncomfortable so that they don't have to be.
And the same thing applies to people of color and people of different
Absolutely.
cultures. If you just take a couple of minutes and just, what are your expectations? Can you meet them? And some of that involves being uncomfortable as the provider. But so what? Isn't that what you're supposed to be there for?
Yeah. And again, I think similar to the Black community, LGBTQIA plus patients may have an increased likelihood of having previous trauma, anxieties, depression, mental health disorders, because just inherently existing as what they are as someone who is maybe not the quote unquote norm is traumatic every day. So you're presenting with this already, and then we're just loading on top of it. And so I think it's important to consider all of those things.
Yeah, it's a lot. It really is a lot. And so we appreciate the listener bringing up this birth trauma, her own birth trauma, and we hope that her emailing us is part of her beginning her healing, and that listening to this will also help in some way. We're trying to salve the wound, like when, old people, they say, put some salve on it and help it heal. the wound of birth trauma, and we are offering some suggestions for starting the healing process. This isn't comprehensive, of course, and it isn't a quick fix, but it doesn't have to be a lifelong burden, especially if you can have the processing help you lead to growth and understanding and healing.
Yep. And your journey may not look the same as everyone else's, but that doesn't mean that it's not totally valid.
For sure. Well, we'd like to thank Baobab Tree Studios, Kenny Blackwell, our friends, family, and all of you who make this podcast possible and motivate us to continue to do it.
Please be sure to subscribe and like us on Spotify, iTunes, iHeartRadio, Google Play, wherever you listen. Like and follow us on Facebook and Instagram at The Midwife Crisis Podcast, or email us at midwifecrisispodcast@gmail.com. Until next time, don't be afraid to share what you're going through.
And in the end, we can have beautiful scars.